Hi, my name is Mikias Tamrat. In this presentation, I'll talk about chronic conditions and exercise prescription. For this, we have our client Michael, a 76-year-old man with type 1 diabetes, and he's come to our clinic for his initial exercise physiology consultation. So, Michael has type 1 diabetes, which is considered as an autoimmune disease where the immune system attacks the body's own beta cells, and this results in absolute deficiency of insulin. Since insulin plays a crucial role in blood glucose regulation, patients with type 1 diabetes require a regular supply of insulin. This is done either by injection or regular insulin pump, which he has. Essentially, in healthy people, what happens in the body is that when blood glucose levels increase, for instance, let's say someone had a meal and the blood sugar levels rise, then insulin is released from the pancreas, and this helps facilitate or transport glucose to the working cells and tissues, providing energy in the process. However, in patients with type 1 diabetes, the beta cells are destroyed by the immune system, so insulin production diminishes over time. Because of this, they must monitor their blood glucose levels closely throughout the day, and this allows them to ensure that they stay within the target range and avoid the risks of hypoglycemia and hyperglycemia. Michael also has hypertension, which is one of the most common comorbidities in people with diabetes. And this is defined as a persistence reading of systolic blood pressure over 140 and diastolic blood pressure over 90 over a period of time. So our client has a blood pressure above this range. He has 145 over 90, which is a risk factor for stroke, heart disease, and kidney disease. At the same time, it's worth mentioning that poor management of diabetes has been shown to be a risk factor for hypertension as well. But other lifestyle factors such as inactivity, being overweight, and drinking a lot of alcohol can also increase the risk of developing hypertension. The other comorbidity is osteoarthritis, which is a disease of the entire joint sparing no tissues. And it can be caused by an interplay of risk factors such as excess weight, joint injury or trauma, and genetic factors. These factors, coupled with mechanical stress and abnormal joint mechanics, can be contributing factors as well. Therefore, these patients usually present with muscle weakness and balance issues, especially weight-bearing joints, particularly the knee and hip, are commonly affected by osteoarthritis. So when we look at treatment options, first line of treatment recommended is exercise, and the current guidelines of non-surgical management for osteoarthritis call for pharmaceutical and non-pharmaceutical management, which includes patient education, weight loss, and exercise. As mentioned earlier, patient education plays an important role in the intervention, and the initial assessments from Michael indicate that there are few risk factors that needs to be addressed prior to prescribing exercise. The first one is alcohol. Patients with hypertension are encouraged to keep their alcohol consumption to under 2 standard drinks per day. And when it comes to alcohol and disease management, the less you drink, the lower the risk of harm. Particularly, alcohol could potentially be a risk factor when it comes to blood glucose management. And in addition to that, alcohol and certain diabetes tablets or insulin can increase the risk of hypos. At the same time, it's very high in calories, so it causes another challenge for weight management. The next one is exercise history. So Michael walks his dog for 15 minutes, and he does that 3 times a week as his form of aerobic exercise, which is insufficient and well under the current guidelines, which is 150 minutes of exercise per week, with no more than 2 consecutive days without exercise. And when it comes to exercise and management of diabetes, there seems to be a lower compliance to the guidelines amongst patients. And this is very common, and this lower adherence is largely caused by fear of hypoglycemia. And few studies have proposed on how to address this issue and protect the well-being of patients. Some of the methods include careful monitoring of blood glucose levels as prior to, during, and post-exercise, as well as adjusting insulin and food intake to physical activity. In this case, the patient will be referred to an endocrinologist for an action plan prior to starting the intervention. Michael is also on hypertension medications as well as insulin pump for his type 1 diabetes. And we need to manage this carefully as it can cause unpredicted response during exercise. So as a precaution, again, a referral to his endocrinologist is required for clearance, and also to obtain an action plan for insulin adjustment prior to exercise. Now let's look at what happens in the body during exercise as seen in this diagram. In people without type 1 diabetes, what happens in the body is that during exercise there's a decrease of insulin secretion and an increase in glucagon, growth hormone, cortisol, and catecholamine secretion. And this happens in response to exercise. These four hormones are the counter-regulatory hormones, which are important as this mechanism help maintain the blood glucose concentration in a tight range that is approximately 4 to 6 millimole per liter. On the other hand, in people with type 1 diabetes, several of these systems are affected, and since insulin exogenous, its levels aren't reduced with response to exercise, and it might even increase due to increased absorption by the skeletal muscles, redistribution, and higher rate of blood flow during exercise. And simultaneously, the release of these four counter-regulatory hormones is reduced in type 1 diabetes patients during exercise. But we also had a look at some of his lab tests, and there are a few red flags. So Michael has a high BMI that is 32.5, and this puts him under obese class 1 classification. However, although BMI can be useful in screening patients, it is not a diagnostic measure of obesity. So because it doesn't assess risks related to body fat distribution. So therefore, it's recommended that we use other measures such as waist circumference and waist to hip ratio. So when looking at Michael's waist to hip ratio, he has 1.12 centimeters, and the normal range for men is under 0.9. And anything above is substantially increased risk of metabolic complications. Next one is his cholesterol levels, and his cholesterol levels are very high, which indicates that he's at an increased risk of coronary artery disease. And finally, blood glucose levels are elevated as well. His readings are 10.2 millimole per liter, and the target range is between 4 to 7 millimole per liter for a fasting blood glucose. And anything above this range is a risk for developing heart attack and stroke. This flowchart has been adopted from the study by Kaczynski et al. From 2019, and they used it for exercise screening and preparation when working with people with diabetes. And based on his initial assessments, Michael would need a clearance from his medical care team. On top of that, additional tests such as the 6-minute walk test for aerobic capacity, ankle range of motion will also be conducted to monitor his progress throughout the intervention. In addition, foot assessment for ulcers, nerve damage, or blood supply issues, which is a common condition in people with type 1 diabetes, will also be administered. This table shows the practical guidelines to limit blood glucose excursions before, during, and after exercise, and these guidelines are from the study by Riddell and Perkins from 2006. It's used for exercise testing preparation based on blood glucose status. Moving on to goals. Clinical goals are reducing comorbidities, that is hypertension and osteoarthritis management, as this can contribute to the lower compliance to exercise. Next one is improving cardiovascular risk factor, that is reducing his blood glucose levels, blood pressure, cholesterol levels, and these are associated with an increased risk of coronary artery disease, and we want to reduce that. And finally, improving exercise capacity to the point where he'll be able to meet the exercise guidelines regularly. These are what we aim to achieve by the end of the intervention, otherwise our long-term goals. Meanwhile, our short-term goals will be just to improve exercise adherence by educating the patient on the importance of physical activity, the fact that he's currently at higher risk of progressing his cardiovascular condition, then gradually increasing exercise intensity and volume, which would benefit him on the long run. Overall, just trying to elicit some behavioral changes and promote a healthy lifestyle. When it comes to exercise prescription, a mix of resistance and aerobic exercise has the most benefit for people with type 1 diabetes. And this slide highlights the intervention from week 1. So in addition, we've included strength training with low load exercises that starts in a weight-bearing position and gradually progressing to a more functional weight-bearing positions, as this approach has been effective in treating patients with hip osteoarthritis. So the exercises include glute bridge or supine hip extension, hip flexion in supine position, step-ups. This is because exercises targeting the gluteal muscles, which are often affected in patients with osteoarthritis, has shown to be more effective. And the rest of the resistance training session mainly focuses on the major muscles of the body. This has been shown to improve muscle mass, body composition, physical function, as well as bone mineral density, etc. So this in-clinic resistance training is done twice a week on moderate intensity because one of Michael's goals is improving fatigue, and studies have shown that moderate intensity resistance training of at least 6 weeks are beneficial for fatigue, energy, and vitality in people with chronic conditions. So moderate intensity exercise at 50 to 69% of his 1RM, that's done for 10 to 15 reps of 1 to 3 sets based on the patient's baseline fitness. So with progressive loading throughout the intervention, we'd aim to get Michael to perform higher intensity and volume of exercise as displayed in this table. These are the highlight of his week 8 sessions, and we'd expect him to be stronger and a lot more fitter. And exercise progression is based on the patient's tolerance, and to do this, resistance is increased first, followed by greater numbers of sets, then increased training frequency. Based on this approach, the aim is to get him to perform 3 sets of each exercise for 10 to 15 reps at 75% of his 1RM. Along with resistance training, we also prescribed aerobic exercise using a walking program, which is important for keeping the heart, lungs, and blood vessels healthy. Walking is a common form of aerobic exercise, especially in older population, and increasing the daily step counts has been associated with reducing fatigue and overall quality of life. Particularly in patients with type 1 diabetes, it increases cardiorespiratory fitness, decreases insulin resistance, and improves lipid levels and endothelial function. These are important to achieve our clinical goals set out earlier. This slide is a guideline for pacing, stretching at the end of exercise, and rest periods between sets. In order to reduce the risk of injury, gradual progression of both intensity and volume is recommended. So throughout the intervention, exercise intensity and volume is increased, and this is identified using the RPE method. And based on the exercise response from previous weeks, a stationary bike training will be added at some point in its home-based aerobic program, or this can be used as an alternative option for the walking program, because what happens in this population is that there's a lower adherence for exercise, and adding some variety of exercises to his program might help with that. These are the list of references used for this presentation. Thanks for listening.